Hi, everybody. I am so excited to be back this year at the San Diego Pain Summit virtual meeting. While I wish we were together in beautiful San Diego like we were last year, I'm so excited for the next few days and connecting with you virtually. This year, I'm giving a very different talk about a very different topic. I'm going to explore trauma and pediatric pain, and I'm going to convince you why this is an intergenerational problem. Now, last year, I took you on a specific journey. I tried to convince you that the pain that a child experiences in the first few days of life can actually set the stage for how they experience pain into adulthood. But today, I'm going to raise the notion and perhaps convince you that what happens before a child is born, how a parent or a grandparent experiences the world, experiences adversity, may actually have the ability to get under the skin and influence how pain is experienced in a child before they're even born. Now, perhaps like last year, most of you work with adults with chronic pain. So I'm going to remind you that when we think about pain and pediatric pain, chronic pain in children and adolescents, this is a huge public health problem. Across the world, epidemiological studies suggest that about 1 in 4 or 1 in 5 children and adolescents experience headaches, abdominal pain, musculoskeletal pain, and the rates of pediatric pain are actually rising. We know now that this costs a lot of money to society, that in the US, it's estimated to cost about $19 billion a year. It's been coined a modern public health disaster as a result. And we know that once chronic pain develops, especially at critical developmental periods in childhood and adolescence, it can really rob children of a typical development. It can influence their cognitive development, their social development, their emotional development, and it has a huge impact on families. But what's really interesting is what we're learning about what happens to these kids when they grow up. We know that youth who have chronic pain in adolescence, up to 2/3 of those kids will become adults with chronic pain if they don't receive proper intervention. But even if we do a good job of treating pain and pain resolves in childhood and adolescence, these kids are at heightened risk for developing psychopathologies, so anxiety, depression, PTSD into adulthood. So there's a broader mental health context. We also know that having chronic pain in adolescence increases the risk of developing opioid misuse problems into adulthood. And we've shown using large nationally representative data that having chronic pain in adolescence is in and of itself a risk factor for the development of lifetime psychopathologies like anxiety and depression and PTSD into adulthood. Now, why are we interested in trauma? Why PTSD? Well, last year I told you all about my research around how children remember painful experiences. And we know that those memories for pain can really influence whether or not pain becomes a problem. So that got me really interested in more pathological forms of remembering, like in PTSD. Those intrusive memories, the re-experiencing. And when I looked to the adult literature, it had been known for decades that there is a high, alarmingly high co-occurrence of PTSD symptoms and chronic pain. But this had never before been really examined in youth. So we compared a group of youth who had chronic pain to a group of youth who didn't have chronic pain, as well as their parents. And we asked them about their PTSD symptoms. And you can see here that the results were pretty striking, the differences. You can see that almost 1/3 of the children with chronic pain reported having clinically elevated levels of PTSD symptoms, compared to about 8% of kids who didn't have chronic pain. and their parents had higher levels of PTSD symptoms. So we found 16% of parents of kids with chronic pain were meeting diagnostic criteria for clinically elevated symptoms of PTSD, compared to none of the parents of kids who didn't have chronic pain. But the big question that we were thinking about was, why is this? Why does chronic pain and PTSD co-occur? And oftentimes when we think about PTSD and chronic pain, we sort of get an idea of an individual that may have had a traumatic and painful injury, say in combat or in a situation like that, that then leads to chronic pain, and the pain becomes a reminder of that physically painful trauma. But when we asked children and parents what their traumas were about, actually, not many of them endorsed that it was about the chronic pain. They were reporting that their PTSD was linked to death that they had experienced in people that they knew, physical illness or hospitalization or medical trauma, or also emotional abuses as well, or traumas. So this got us really curious about what is underlying these two conditions that lead to this high co-occurrence. And there's also this very compelling question, chicken egg question, around whether or not early life trauma may increase the risk for developing or worsening chronic pain later in life. What comes first? And this is a really tricky question to disentangle, but we're beginning to. So together with our colleagues, we put our heads together and looked to the literature. We looked at the PTSD and trauma literature. We looked at the chronic pain literature to try to get some clues as to what these mechanisms or shared vulnerability factors might be that might lead to the development and the maintenance of both of these problems. And in this first model, we were really interested in factors in the child. So both from the PTSD literature and the chronic pain literature, there were shared risk factors, things like avoidance, cognitive biases, including memory biases, depression, and especially hyperarousal or sleep disturbances, which were emerging in the literatures as being really critical for the exacerbation of both of these problems. We also know that trauma can influence the developing child's brain, as can chronic pain. So there may be shared neurobiology that's underlying this co-occurrence. And then when we look at kids, we have to look at parents. What is the impact of parent trauma on a child's pain experience and trauma experience? And then with our neuroscience colleagues, we got really interested in neurobiology, that there may be genetic and epigenetic reasons and factors that underlie why a child develops both PTSD and chronic pain. We know that parents of kids with chronic pain, about 50% have chronic pain themselves, and many of them also report trauma. So what is this intergenerational risk, and what are those neurobiological factors that may account for that risk? So when the previous research was cross-sectional. We asked kids about their trauma, we asked them about their pain, but we didn't follow them over time. So in this study, we followed kids who came into the chronic pain program with headaches, musculoskeletal pain, abdominal pain, pain that didn't have an underlying injury. Often primary pain was the condition. And we could see that when kids come into the clinic and we follow them over time, those who came in with higher levels of pain-related interference or disability, those were the kids whose interference and disability was getting worse. That's not so surprising. But even when we control for their baseline pain interference, kids who had higher levels of PTSD symptoms showed a worsening of their pain and disability over time, really pointing to the importance of these PTSD symptoms in exacerbating or worsening pain over time longitudinally. Now, PTSD symptoms are the symptoms of trauma. So re-experiencing, hyperarousal, avoidance, alterations in cognition and mood. It's how our trauma affects us in the present. But we also got really interested in adverse childhood experiences. Adverse childhood experiences, or ACEs, are 10 different types of experiences that one can experience before the age of 18 that include physical, emotional, and sexual abuse, physical and emotional neglect, and 5 types of household dysfunction. So these include someone in the household that had a mental illness, a relative who had been incarcerated, a mother being treated violently, someone in the household that had a substance abuse problem, and also separation and divorce. We got really interested in ACEs because of this early research by Folletti and colleagues that were the first to really examine the impact of ACEs on health over time. And so what they did is they followed thousands of people who had received a medical evaluation in their primary care physicians' offices. And then they mailed them a survey to look at their mental health and physical health, and also whether or not they endorsed a variety of these ACEs. And the findings were really striking. They found that ACEs were prevalent, so you can see the prevalence there, only 36% experienced no ACEs, so they were prevalent. But what was really important was that the higher level of ACEs that you had, particularly if you had 4 or more ACEs as a child, as an adult, you were far more likely to experience alcoholism, drug abuse, a suicide attempt, depression, and even more shocking, you were more likely to have life-threatening physical health problems. So these more ACEs were linked to greater heart disease, cancer, chronic lung disease, skeletal fractures, and liver disease, really showing that ACEs, these adverse childhood experiences and trauma, actually set the stage for mental and physical health and have a robust effect on that. And since then, in the last 20, 30 years, it's really been shown that this is also a key culprit in the adult's chronic pain experience. So we wanted to see what the prevalence of ACEs were and what the influence of ACEs were in our pediatric chronic pain patients. And you can see here that when you look at the prevalence of ACEs in these kids, it's relatively high. About a quarter of kids are reporting that someone in the household has a mental illness. About 1 in 4 are saying that their parents had separated or divorced. And you can also see the relatively high levels of emotional abuse, physical violence in the household, and physical abuse. And so this study was the first to really show what are the prevalence of ACEs, but then of course we want to know, does that increase risk for poor outcomes in these kids? And not surprisingly, it did. So we find that kids who report higher levels of ACEs, particularly 3 or more, are reporting lower quality of life over time. They're reporting greater symptoms of major depressive disorder, and they're showing higher levels of PTSD. So in this case, higher levels of ACEs in these kids, which was quite prevalent, was really tied to their functioning and their mental health. So I hope I've convinced you that there is a connection between trauma and pain, not for everybody, but it is one important risk factor for the development of chronic pain and the worsening of chronic pain over time. But the big question is why? So we went back to our models and we got really interested in sleep disturbances. This is an op-ed from I think the New York Times, and it's just an anecdotal report of an individual whose sleep disturbances led them to commit suicide. And if you look to the mental health literature, it's pretty clear that insomnia is a powerful driver of mental health disturbances and even death in the case of suicide. And when we look at kids, we have to appreciate that we are, as a society, sleep depriving our kids. The rates of insomnia and sleep disturbances, particularly around the point of puberty, is really, really high. And it's been coined, an epidemic in teenagers. Now, why is that? Well, we have a lot of social reasons why it is difficult to fall asleep, increasing screen time, phones, none of these things help with going to sleep on time. But also, if you look at the biology of a developing adolescence, There is actually things that are happening that sort of create what is referred to as a perfect storm for sleep disturbances. We have a circadian phase delay, but we also have a slower rise of sleep pressure. And so the biology and the society is against these kids for really getting sleep deprivation under control. And this is really important because we know that at around the time of adolescence, a critical developmental period for brain development and social development, we see a dramatic decrease in the total duration of sleep per night. So we go from about 8.5 hours of sleep a night in a teenager to about under 7. And to put that in context, there's some compelling empirical studies where they've used sleep restriction to look at the impact of sleep restriction on cognitive functioning and emotional functioning. And even 30 minutes of restriction can lead to pretty pronounced difficulties in emotion regulation and cognitive functioning. So, what is the connection with pediatric chronic pain? Why are we interested in sleep disturbance as a potential reason or mechanism in this trauma and pain relationship? So together with my amazing colleagues from Monash University, Rochelle Machazik and Janaea Christensen, we published a review of the literature. It was mostly drawing from the animal literature and the adult literature because there's just a dearth of research in kids. And essentially, when you look at the literature, there's evidence that what happens to the brain when a person is sleep deprived is very similar to what happens in the brain when a person is in a chronic pain state. So there's a shared neurobiology that may underlie this sort of sleep deprivation, chronic pain relationship in adolescence. And there's also more and more compelling epidemiological research with large samples around the world showing that sleep disturbances, even in young children, even in early childhood, can actually increase the risk for developing chronic pain in adolescence. And then when we look to the mental health literature and the trauma and the anxiety literature, we see the same thing, that early sleep disturbances in early childhood increase the risk for the development of mental health problems. So in this recent paper, we were interested in what the role of sleep disturbances were in explaining this co-occurrence of pediatric chronic pain and PTSD over time. And you can see here that one of the reasons that higher levels of pain interference at baseline lead to a worsening of pain interference over time is because the kid's sleep is disturbed. It's because they're experiencing insomnia and poor sleep quality. And interestingly, that we also see this for this connection between PTSD symptoms and pain. One of the reasons why high levels of PTSD symptoms lead to a worsening of pain over time is because the kid's sleep is disturbed. So this really raises the importance, we think, of assessing PTSD symptoms because it's a powerful driver of pain. But also, this is really pointing to the need to intervene on sleep to improve pain and potentially PTSD over time. And there have been some studies showing that cognitive behavioral therapy for insomnia can actually reduce trauma symptoms. And so there's more and more research and excitement about targeting sleep to really get these co-occurring trauma and pain symptoms lowered. But I go back to the chicken and egg question. Is it pain that's leading to PTSD, or is it PTSD leading to pain? What is the influence of early life trauma on increasing risk for pain later on? And this is really hard to understand in human samples. So this is where we turn to our collaborators who work with animal models, where we can really tease apart this chicken egg question. So together with Rochelle, again, Dr. Machazik from Monash University and her amazing PhD student, Sabrina Sahlberg, we did a study to really tease apart this question and start to unpack it. So what they did is we took animals who were just born, these were rodents, and half of the animals underwent an early life trauma or adversity, they were separated from their moms. And this is an animal model of neglect. We compared them to the animals who were reared normally and not separated. And then as the animals grew, we looked at their anxiety behaviors and their pain response and their sensitivity. And at around the point in development that coincides with puberty and adolescence, we sleep deprived all of the animals, not unlike what society is doing to teens nowadays, right? After that sleep deprivation, all of the animals underwent a hind paw incision surgery, a painful event that we could then see what was the influence of early life trauma on later pain modulation in the adolescent animal. And then we were able to tease apart what are some potential epigenetic factors that may be underlying this trauma-pain relationship. And you can see here that we showed that the animals that had had this early life trauma, this maternal separation, when they grew up, they tended to show more anxiety behaviors. Initially, they showed differences in pain thresholds, and at that surgery, they showed a heightened pain sensitivity. So early life trauma was influencing these animals' ability to modulate pain in the adolescent period. And what was really exciting is we started to uncover some epigenetic changes, some that underlied this relationship. So we showed that in the animals that had experienced this early life trauma, they showed an increased expression of the glucocorticoid receptor that is responsible for modulating the fight or flight response. And so we're seeing differences in those animals that experienced the early life trauma and those that didn't, suggesting that there may be this epigenetic change that's underlying this inability or this difficulty in modulating pain later in life because of that trauma. We also saw an increased expression of COMT in the animals that had experienced the early life trauma. And this is an important factor that's responsible for reward seeking and pain modulation and sensitivity. And so in this study, we are now beginning to uncover the causal relationship between early life trauma and adolescent pain. And we're starting to identify some epigenetic factors that may underlie this connection. And very preliminary, but we have data now in our pediatric chronic pain patients, as well as their parents, using saliva to start looking at whether we're seeing similar epigenetic changes in the human participants, the patients that we see. And you can see here that we are seeing that parental ACEs, particularly household dysfunction, is related to a decreased expression in COMT in the parents. And we see that parental maltreatment is related to a decreased expression in the DRD2 receptor in female children. So this is starting to show us translationally the connection between trauma and pediatric chronic pain and this intergenerational transmission, and potentially the role of epigenetics in that transmission. And this is a really, to me, fascinating question around how might early life trauma in our parents get under the skin to lead to epigenetic changes and behavioral changes that can then confer risk to the developing child, even before they're born, for developing pain later in life. So when we look to this intergenerational transmission literature in the areas of mental health, we see a clear connection between early life trauma in a parent and poor mental and physical health problems and issues in a child. We see more developmental concerns. We see poorer general health, more internalized and externalizing mental health problems, and poorer socio-emotional functioning in children. And so the higher rates of ACEs in parents is linked to poor outcomes in children. And this is thought to be through both biological pathways and psychosocial or parenting behavioral pathways. So in this recent study, we looked at what was the prevalence of ACEs in parents of kids with chronic pain. And you can see here that the prevalence was high. In fact, the prevalence of ACEs in the parents of kids with chronic pain was higher than in the original Folletti study that I showed earlier. You can see that parents of kids with chronic pain, 37% are saying when they grew up, there was someone in their household with mental illness. About a third reported a parent being separated or divorced. And you see about a third reporting that there was someone in their household that had a substance use problem. And look at the rates of sexual abuse and emotional abuse. Now, when we compare these rates of ACEs to a sample that we collected in primary care in the same geographical region, we really see a difference between levels of physical neglect. So we're seeing higher levels of physical neglect in these parents than we see in other community-based samples. And maybe not surprisingly and consistent with the adult literature, parents of kids with chronic pain who have higher levels of ACEs are more likely themselves to report higher levels of chronic pain. And this is important because in a lot of our research and our colleagues' research, we're showing that parent chronic pain status is one of the most robust predictors of child pain outcomes. And 50% of these parents are reporting chronic pain themselves. So ACEs is a driver of the parent's chronic pain problem. It's also a predictor of whether or not a parent reports higher levels of PTSD symptoms. So parent ACEs in this chronic pain, pediatric chronic pain sample is prevalent, and they're also related to their mental and physical health. But what excited us and surprised us was that we do not see evidence of a developmental cascade. So in this sample of kids who already have chronic pain problems, the level of their parents' ACEs was not influencing whether or not these kids had higher levels of pain interference or disability over time, which we really think is important because it speaks to, yes, early life trauma is a risk factor. Yes, it can lead to health problems. And yes, it may lead to the development of chronic pain, but we're not seeing it influencing how the worsening of pain in these kids. And we think that this really highlights the resilience of these families. I'm going to share with you a paper that really has been blowing our minds in my lab that has been examining positive childhood experiences, examining resilience, so factors that can buffer against the negative effect of trauma. What are positive childhood experiences? Well, there's 7 things. Whether or not these things happen to you. You had the ability as a child to talk to your family about feelings. You felt an experience that the family was supportive in difficult times. When you were a child, you enjoyed participating in community traditions. You felt a sense of belonging in high school. You felt being supported by your friends. You had at least 2 non-parent adults who generally cared about you. And finally, you reported feeling safe and protected by an adult at home. This is simply whether or not these experiences happen to you. And really, most of them are tapping into, did you have social support and attachment figures that were there for you during your childhood? And in this study, when they looked at adults who had high levels of ACEs, not surprisingly, higher levels of ACEs were linked to worse mental health and socio-emotional difficulties over time. But the higher level of positive childhood experiences that one had buffered against the negative effects of adverse childhood experiences. Positive childhood experiences are the antidote to early ACEs. And this to me is so powerful because think of the interventions that we could put in place to provide more social support for these kids, even in situations where trauma is an issue in their parents and in their own lives. And to look at a colleague of mine here in Calgary's literature, that just to point to the power of social support in fostering resilience, Jerry Giesbrecht and colleagues followed a group of pregnant mothers who reported on their ACEs, and they followed the mothers over their pregnancy and looked at their infants at 6 months to look at their stress reactivity. And in this study, The relationship between higher parental ACEs and the child's stress response in infancy was actually buffered by social support. So this is a huge, huge protective factor. And when we listen to the lived experiences of the families that we work with, we see a lot of these positive childhood experiences. We see a lot of resilience. And this is probably why we're not seeing that developmental cascade. So what do we do about it? What should we do? What should we do about trauma and pain and its co-occurrence? When I used to present this data, I used to have a period after the word ask. I used to feel like we should ask everyone about their trauma. It's so important. And I do believe that asking individuals and these kids and these parents about their own PTSD symptoms is important. And you can ask about PTSD symptoms without actually digging into what drove those symptoms and reliving or potentially re-traumatizing individuals. Higher levels of PTSD symptoms are certainly linking to poorer pain outcomes in kids. But this is a nuanced discussion, because when we ask about early life trauma, particularly in adults when their childhoods have been long over, we do run the risk of re-traumatizing individuals. And so we've sort of moved away from unilaterally recommending that we ask about ACEs, particularly in parents. When we ask about kids, we have an opportunity to protect them and put resources in place. So this is a nuanced discussion that I'm excited to explore with you during the summit. And what I've gotten really interested in, and also, other researchers, who are doing this work, is this idea of maybe revolutionizing how we provide care to individuals with chronic pain. Maybe we should all be taking more of what's called a trauma-informed approach to our care. What is trauma-informed care? Essentially, trauma-informed care involves doing what we just did, learning about the impact of trauma, the high prevalence of it, but the impact of trauma on health. It's the knowing. But then it's also influencing how we communicate with our patients, how we can maybe notice for red flags, how we basically adopt an approach to care where we assume that many people may have experienced these adverse childhood experiences, these traumas. And so this is a very exciting movement that many people are starting to explore about this notion of how we may be able to transform not just our interventions, but the actual overall approach of how we provide care to our patients and families. So I want to thank my amazing graduate students and staff, my collaborators all around the world. They are an amazing team who are really spearheading this work, and I am the messenger. They are so brilliant in doing this, so I couldn't do it without them. And I thank my funding agencies that have provided support for this work. And thank you to Rajam for inviting me back to this summit. It's a wonderful community, and I am so excited to fully engage and connect with all of you this year so that hopefully we can be together next year. Thank you.